Good morning, everyone, and welcome to the continuing COVID-19 series of Teletown Halls brought to you by the Detroit Regional Chamber. Thank you all for joining us here today, and hopefully wherever you are, it's sunny like it is here. Today, we have a couple of very interesting guests to talk to continue our discussions around COVID-19. But first, let me tell you, I will be chatting with our participants here in the studio for probably about 10-15 minutes, and then I'm going to turn it over to my colleague, Brad Williams. He'll be watching the chat box where you enter your questions. So to remind you, you can put questions into the chat box. There's a bar on the far right of your screen to do that. I also like to apologize up front that we don't always get to all the questions, but we try our best. So today, I'm very excited to welcome Dr. Samuel Stanley Jr., who's the president of Michigan State University, and Dr. Randolph Rasch, who is the dean and professor of the College of Nursing. We will have Dr. Stanley with you on video. Dr. Rasch is joining us by audio because of some technical difficulties, but you will still be able to hear him. So, gentlemen, let's jump into our discussion today. First, let me welcome you both. President Stanley, you have an extensive background as an infectious disease expert. How has that prepared you to lead a large Big Ten university during a pandemic?
Well, thank you, Tammy. First of all, it's an absolute pleasure to be here, and it's good to be in front of the Detroit Regional Chamber, and glad for this opportunity. I think when the Board of Trustees, hired me for Michigan State University, probably being an infectious disease doctor was maybe not highest on their qualification list. And of course, who could predict what was going to happen and things would change? I think it's obviously made me very comfortable in thinking about this illness and the outbreak and pandemics. My work was in emerging infectious diseases. Actually, I ran a very large center devoted to ways in which we can help prepare for this. So I think, again, things I've thought about before have come to pass. So I think from that point of view, I'm comfortable in dealing with it, comfortable in thinking about the medical aspects of it in ways that others might be. But fundamentally, the principles for me and any other university president, I think during this time have remained the same, which is how do we keep people safe while delivering our content, delivering our wonderful educational mission, as well as our research mission. And I think that's been really at the core of what I and every other university president has been doing.
President Stanley, I'm sure you've been following the vaccine's development. Can you give us your take on the safety, efficacy of the individual vaccines, but also the plans underway at MSU for vaccination?
So Tammy, that's a great question, and I think it's really important. I think one of the things that people don't realize or maybe don't really fully appreciate is what a really magnificent accomplishment it is to have these vaccines and have them so quickly. We had a head start. As you may remember, in 2002, there was the SARS-CoV virus, what we just called SARS at that time. We now call SARS-CoV-1, which led to an outbreak, as I said, in 2002. And after that outbreak, a pretty extensive amount of work was done on SARS virus. And we learned a number of things about it, including how it entered into cells, what were the key proteins. And there was actually some early vaccine work done on SARS-CoV-1. And so that really set the stage for work on SARS-CoV-2. But I couldn't be more amazed at how research from universities, research from industry, and of course, came together to develop a vaccine in this very short amount of time. So we have 5 vaccines currently that may be used in the US. 2 have already been approved, of course, are in use, Pfizer and Moderna. These are both very safe and effective vaccines. They're based on messenger RNA that's from the virus, but they don't involve the virus in our cells. They involve introduction into the cells of this messenger RNA, but no live virus is there at all. That's one of the things that makes them so safe going forward. And they've proved to be very effective. So there have been a couple trials, a large one for Pfizer, a large one for Moderna, with tens of thousands of individuals. And the data suggests they're very effective, maybe 95% or so effective in preventing disease disease, hospitalizations, severe SARS. They do a very good job at that. And probably the information coming out from Israel and other places where there's been a large number of people vaccinated and great follow-up indicates that they're probably effective in reducing transmission as well. How effective they are, I think we still need to see, but anywhere from 33 to 50 or higher percentage in terms of reducing transmission is being seen as well. So they're very, very good as vaccines go, and very comparable to measles, mumps, and rubella or other vaccines we may be familiar with. We don't yet how long the duration of immunity will be, so that's a question, how long people be protected after vaccination. We still need to study that, but right now they look like very, very good vaccines, as I said. In terms of what we're doing in Michigan, we haven't received vaccine from the state yet. We're not a large hospital or health system, so we're waiting. We have an application in there to receive vaccine, but we're cooperating with Ingham County delivery. And we've set up our pavilion, which was used for livestock shows and other events. It's been converted into a large vaccine center with drive-through, 6 lanes of drive-through and high capacity. We're running it 4 days a week right now, about 8 hours a day, but we could gear up and do more when more vaccine becomes available. We are really interested in partnering with public health and anybody else in delivering vaccine as soon as we can to the people of Michigan State University, of Ingham County, and the state. We'll do everything we can to help in that effort.
Well, that's great. I've heard really good feedback on the great performance of Ingham County right now with its vaccination activities. Dr. Rasch, let me welcome you now. You co-chair the Governor's Task Force on Racial Inequities, which was formed before the pandemic really impacted our state. But you've now shifted the task force's review to include how marginalized communities have been impacted. What can you share about that work and the vaccine deployment?
Tammy, thanks. I want to thank Dr. Stanley for inviting me to join him. Can you guys hear me?
We can.
Great. So, soon after the task force was formed and we were focused on racial disparities, primarily on African Americans, but as soon as we started, we realized that to protect not only them, but marginalized communities in general, and the health of the population of the state in general, we needed to widen what we were thinking of. The task force originally started, looking at, we were concerned that marginalized communities weren't being tested, because most of the tests required that you come into a clinical setting or you drive up, and most of those individuals didn't have the ability to drive up. And so right away, what we did was begin looking at really what I consider is going to be a model for healthcare, and that is go where folks are and where they're needed. So the first thing we did was leverage the ability to get testing to where people were, in community sites, through mobile centers, things like that. And as soon as we began to do that, the other things that we added into that was to see if they had primary care providers, if they had coverage through the state or other insurance companies to get primary care, because that, of course, increased their vulnerability. So right from the beginning, we were doing a number of things. The task force was configured into 2 work groups. One was a testing infrastructure, and the other one was a primary care connection work group, and I chaired the latter. So we were also looking, using the format that we were testing to get testing into the communities, to think about that already for vaccination. And our trial runs for vaccination was to increase the number of people who received influenza and pneumonia vaccines. And those communities, don't really trust immunization. So there was an effort to get the word out to do that as well. So we're using that now to leverage getting the coronavirus immunizations to those communities as soon as Dr. Stanley noticed, as soon as the allocations show up. The other thing I would say that the governor has been really thinking and leading in this is that there's now a commission looking at equity of vaccinations for all Michiganders. And so all Michiganders are included in this vaccination strategy, with some emphases on those folks who can't get it. But, and I will just say the last thing is that a lot of information can be found at Michigan Department of Health and Human Services. So a lot of those specific questions are really, they've been very transparent in what they did.
Dr. Rasch, I'm sorry.
Did I answer your question?
You did, thank you. Dr. Rasch, in November, the Detroit Regional Chamber conducted a statewide poll of Michigan voters. And at that time, 57.8% of white voters indicated that they will get the vaccine, but only 32.9% of Black voters said the same. What is currently being done at the state level to build more trust among the Black and more diverse populations to encourage safety and efficacy of the vaccine?
Well, that's a great question. So that I'll follow up on some of what I said. So one of the first things that MDHHS had done, and our advisory task force advises MDHHS. So one of the first things we did was to begin to do those kinds of communication regarding immunizations in general. And I mentioned influenza and pneumonia. We've had tremendous community partners across the state. So the task force was appointed by the governor, but there are community organizers and community organizations who have their thumbprint on the beat of what's going on in the communities and listening to what the concerns are, and in real time beginning to adjust those messages to get the word out and to build trust. Some of it is a basic understanding of what immunizations are and what they are not, because people don't really understand that, you know, it's a shot, it's medication, it's not the same thing. So there's a general misunderstanding of that. So we're working really hard in real time. So even now as we speak, MDHHS is looking at data and giving feedback to the task force to help attenuate the messages that they're giving. But just to give you an example, one of the things we know, and we have to remember that any community is not a hegemonic community. So anecdotal information that we're beginning specifically from the African American community is that there's a sort of general distrust, but we're finding older people who have an established relationship with a healthcare provider are more likely to say that they will get the immunization that's available to them. There's another group that are really looking at how the testing was done for the immunizations, and their concern is that they felt that the African American community wasn't represented well in the testing. So there's information that has to get out about testing, what that means in terms of we're all human beings, and there's some things that probably aren't that different when you look at that, and the safety and efficacy of the vaccines. So I think one of the big things we're beginning to look at as well is who are the different members of those communities, who are the different subpopulations, and what are the messages that they need to help them be more comfortable. And then the overall approach, I think, too, is the continuing effort to get people involved in primary care, to have a primary care provider, because you're more likely to trust the person that you see personally for your health care. So we're using this as a way to try to get folks into services and to begin those trusting relationships.
Great, thank you. I do have more questions, but I think maybe we'll take a break from me and bring in my colleague Brad Williams to see if we have some questions from our attendees.
Thanks, Tammy. I wanted to ask you, Dr. Stanley, one of the things we were talking about a little bit beforehand, and one of the questions that I think our audience has is about lessons learned for the future for your students from this pandemic. As we go forward, hopefully, you'll be able to welcome students back on campus to a normal learning environment soon. But what are the lessons you've learned for, hopefully, we don't have another pandemic like this, but what are the lessons you've learned about resiliency in higher education that you can apply to the university going forward? So if we, the next public health event we can avoid these sorts of situations going forward?
So it's a very good question and a complex one. So let me talk about some lessons learned just in terms of the university and students, and then I may broaden about how we get better prepared essentially for this kind of thing in the future. So in terms of what we've learned, I think we've learned how important the in-person experience is for students. So even though in many cases we've asked students to stay away from campus, in many cases they've wanted to come back because they consider it a critical part of their learning experience. The paradoxical element of this is we've also learned that online can work very well in certain kinds of classes. And I really admire the work that was done by our faculty and staff in pivoting with really a moment's notice from teaching in person to teaching remotely, which we had to do, and particularly in the early phases of the pandemic where we didn't know exactly what we were dealing with. I think since then we've learned that even in a pandemic, we can teach safely with social distancing, with mask wearing, which is absolutely critical. We've been able to develop protocols that allow us to teach safely. We've actually been able to develop some protocols primarily by moving to single rooms and others that make dorm life relatively safe as well. And that's very difficult for congregate housing. So there are some ways we can mitigate things, but this vaccine is going to be a game changer in terms of what we're able to do or not change. It really will, I think, change things in a way we haven't seen before in terms of opening things up, but it's important. I think, the other thing, and we were talking about it earlier before folks joined us, is it's changed a little bit of our view of work. And so, faculty can teach remotely. Back office functions of the university can all be done remotely, we're learning. And it's going to change, I think, the way we utilize space and the way we think about work and the way we support our employees, our faculty and staff at MSU, I think is changing as well. So that's going to be something we think about going forward. To the broader question of how we do a better job of preparing for this, I think this has exposed a lot of weaknesses we had in our systems that we weren't aware of, and that's what something like this does. And so we just need to learn lessons from it. This is not to point fingers at any given group or anyone, but just to say that we've learned some things we need to do better. So one is, I think our public health infrastructure needs to be strengthened. I think our understanding of what is available to us as a country. So I think one of the challenges we've had is our response has been more on a statewide basis. In many cases, it's been embedded as the whole country. And while we are a big country, and we do certainly expect and respect the rights of our states, there are some things often where national mandates may be definitely needed. And I think national policies may be needed because we don't permit any really restrictions normally to travel between states. And so really an infection in one place can really rapidly spread to another. So we need national policies to deal with that. And I think we need to do a better job. And finally, research into these things. As I mentioned before, research that was done on SARS-CoV-1 really set the stage for vaccines against SARS-CoV-2. If we hadn't had that, this would have taken longer. There's no question in my mind. So our ability to continue to support research at universities and to support pharma in their work as well, it's very important, I think, that we have that kind of support and we continue to do that as a country. That will help better prepare us for what comes next.
Yeah, I think President Stanley, your point about the research that already went into the SARS-CoV-1 vaccine is important and something I hadn't even thought about or been aware of. And so that's an important point to make. And the research that our research universities do shouldn't be forgotten as we think about this and as we make policy decisions and spending decisions going forward. But our research universities are also instructional universities. And so Dr. Dean Rasch, I want to ask you about how this has changed or you anticipate will change then the curriculum and instruction model for healthcare delivery going forward, and how you anticipate instructing your students differently in healthcare delivery going forward.
Well, thanks for that question. I think there are two things. I'll speak for the College of Nursing, but I'll risk speaking for the Colleges of Health Sciences, both our College of Human Medicine and College of Osteopathic Medicine. I think for all healthcare students, one of the things I say to our students is, and to our faculty, every nurse is a public health nurse. So I think every physician has to know that too. And back in the olden days, back when I was being educated, we always did something called case finding. And it is always to have a high incidents of suspicion about what's going on with patients that might be infections. So training from the very beginning is to always think about not just the patients you're taking care of, but the patients that are the patient population that might be exposed. And what is your role as a healthcare provider? So I'm from Michigan originally, and my first job was a public health nurse in Benton Harbor, Michigan. And that was, as a public health nurse, we covered a variety of things, but of course, infectious disease was something we always thought of. So nurses and physicians, whatever their practice is, whatever patients they're seeing, they have to think that way, and we have to make sure that we put that in our curriculum. So I have thought about, I just did an editorial for a special edition of a journal on for nurses that was on infectious disease. And one of the things I said in the foreword is talked about the new infectious diseases to come. So we know from an article in Nature magazine that prehistoric ice is melting. And as it's melting, we have prehistoric viruses and bacteria that are being released. And I think they're finding that those are alive. So we don't know what we'll be facing. So it's all of us on the front lines who need to be thinking, if we see a patient, is this an infection? Is it an infection that we haven't seen? And the reality right now is that over the last 5 years or so, we have seen infections that we don't normally see in the United States, but we have to think that way too. Ebola, Zika, all of those were things that were endemic in other parts of the world, but were showing up here. So a part of our education has really to make sure that all of our students in the health sciences think of that. So when they see a patient, maybe it's not a new infection, but it's an infection we're not used to in the United States, and we have to be on it right away.
So the last question from me, Dr. Stanley, and then I'm going to hand it back to Tammy. And I will say I have been honored to volunteer at the clinic at the MSU Pavilion, and it is as cool of experience as you described. But Tammy and I's boss signed a letter this week, encouraging the governor to explore different vaccine distribution methods and deployment. Based on what Dr. Stanley, as an expert in this field, are there other ways that the state should consider deploying the vaccine out to state residents?
So thank you, Brad, and thank you for your service and volunteering. We appreciate that. I think that's a very important question. I think it's also one, I don't want to be in the position necessarily of second guessing when I'm not on the inside and how those plans are being done. So I'd just say the following, that I think if you look at countries around the world that have been successful, I think the simpler you can make any regimen, the better. So in terms of deciding who's going to be vaccinated, I think one avoids some controversy sometimes and some concerns by just breaking it down and understanding who the most vulnerable population is. And for SARS-CoV-2, there's no question that age is the biggest determiner of vulnerability overall. So if you look at the mortality, more than 111,000 individuals over 85 have died. If you look at people between the ages of 15 and 24, about 700 people have died. So it tells you there's a vast difference in susceptibility to severe disease based on age. So I think what was done by the state to immediately move very quickly to going to 65 and older was the right thing to do. I think we need to continue to pursue that. I think we need to move down the age level, and that to me would be probably a more efficient way in some ways in terms of making it simpler as to who gets the vaccine or doesn't get the vaccine. The other complicated thing is just how you distribute it and who delivers it. And again, that's really complicated when supply is limiting. So the first thing we need to do is, I think as the current administration is doing, is really pushing the drug manufacturers, the vaccine manufacturers, to push their production as much as you can and do everything we can to push production, because the more vaccine comes available, the less concerns we may have about who's getting it, because everybody at some time would have access to a dose. So I think increasing the amount of supply that's available and then trying to simplify in some way the distribution and the identification of who could receive it are two key things to do. And of course, as Dr. Rasch has talked about, we want to do this in as equitable and fair way as we can.
But hopefully the good news out of the FDA today on the Johnson & Johnson vaccine will help increase the supply soon. So that ends the time I have for questions, Tammy. So I will hand it back to you. But thank you, President Stanley and Dean Rasch, for your time today.
Thank you very much, Brad. So President Stanley and Dr. Rasch, we've got just a couple minutes left before we end, but what I'd like to do is pose a question to both of you. Either one can answer or both if you would like, but you know, we've spent some time talking about vaccination access and efficacy, but there's also that question of when do we get to herd immunity? So I'd be really curious, as medical and science experts, what are your thoughts on when we could reach herd immunity and what will it take to get there?
So I think, again, you know, we've got, you know, great experts like Dr. Fauci and others who are opining on this. And so I don't know if I have any additional information to add to that. I think conventionally one would be looking at, you know, you'd like it as high as you can in terms of the percentage. Let's just put it that way. I think that's the simplest thing. But my own impression is if we get to 70% of people vaccinated, adults, we would be at a very good place. And I say that because I believe that probably we know at least, you know, we're at 28 million cases in the US of confirmed of COVID-19. So at least 10% roughly of the population has been infected already. So they already have some level of immunity, and a single dose of vaccine probably boosts them up to a level that may approach people who've gotten 2 doses of vaccine otherwise. I don't know that, but that's a supposition, but it's not a bad supposition. So they already have some immunity. We have 70% of everybody else vaccinated. To me, you start to get to a point where I think we would definitely see reduction in cases and transmission just based on herd immunity. But my goal would be to have everybody vaccinated. I think, as we said, it's a safe, effective vaccine, and that's the way it gives us the best chance of really, you know, and again, there's debate and controversy about this, but could we get to a stage where we eradicate the disease in the same way smallpox was eradicated, or at minimum reduce it to a disease more like the flu, which is problematic every year but doesn't cause the same kind of mortality. Those are both 2 good outcomes, but the notion of eradicating it, I think, is good. Although I say there's experts who think that may be difficult.
Dr. Rasch, is there anything you would like to add?
I would just expand on what Dr. Stanley said. One of the things is to understand that there are various ways of getting to herd immunity, and some of what's been out there has been controversial. The effective, safe way to get herd immunity is to get the population immunized so that it's through immunization, not being exposed to active disease. That's the safe way to get us there. And the only other thing I would add is that I really would recommend that if people have a chance, if you go to MDHHS or just Google the Michigan COVID-19 vaccine strategy, you'll pull up what is planned, and some of what Dr. Stanley spoke of is in there, and it has to do with getting it to lower age folks and really looking at the CDC Social Vulnerability Index. And I'll just say to you what that includes is socioeconomic status, household disposition, and disability. And it isn't just age 65 or 60, it gets to age 17 or younger. So there are a variety of things in there that I think if you get a chance to look at it, and it seems long, but the information is very condensed, so each page is readily understandable. Anybody would look at it and go, oh, I see what that is. And if they have questions, there are ways to get that information to the coronavirus task force. And the last thing I would say about that is we had been meeting weekly. Now what we're doing is responding to issues that MDHHS does. But there's an official meeting every Friday at noon that anyone can join because it's a town hall, and you can hear the discussions of the task force, and there's input from our citizens around the state about concerns that they have. So I would just put that plug out there, but look at that strategy and also join the conversation on Fridays. And thank you for this opportunity, and thanks to Dr. Stanley again for including me.
Well, thank you. So we have had Michigan State University President Samuel Stanley and Dr. Randolph Rasch. This has been an excellent discussion. I think we could go on for another 30 minutes, but we are so fortunate to have medical and science experts such as yourself to continue to help educate and do what can be done to stop this pandemic. So thank you for your participation today.
Thank you so much.
Thank you very much.
And to all our attendees, thank you for joining us today, and watch for future sessions. Bye-bye.
Bye-bye.
Thank you.